As you know, steroid refractory GVHD still represents a medical need. Both acute and chronic GVHD are characterized by a complex pathophysiology, particularly in acute GVHD. Alloreactive T cells and cytokine storm are the main phenomenon which have to be contrasted, while in chronic GVHD also B cell, alloreactive B cells and profibrotic cytokines represent important actors of the final damage. ACP has been introduced in the treatment of patients with T-cell cutaneous lymphoma in 1978, followed by the application of this treatment also in patients with a solid organ transplant rejection, and only in the late 1990s ACP has been proposed for treatment of patients with chronic GVHD, showing best results, particularly in patients with scleroderma-like features. ACP mechanism of actions is still debated, but we consider this approach as an immunomodulatory approach, where the cells, leukocytes are irradiated by UV radiations, leading to apoptosis of leukocytes, and the reinfusion of these leukocytes is able to induce the generation of tolerogenic dendritic cells and apoptosis of alloreactive T cells, skewing the cytokine Th1 in Th2 fashion. So, as for chronic GVHD, ACP has been proposed in first series showing best results in patients with skin involvement, and I would like to remind the most important retrospective study by Currell in 71 patients with steroid refractory chronic GVHD with multi-organ involvement, showing a 71% of overall response rate, and there is only one prospective randomized study conducted by Mary Flower in 95 patients with steroid refractory chronic GVHD. In this case, the main endpoint was not the overall response rate or the outcomes, but was a specific improvement of total skin score. Unfortunately, this endpoint has not been reached, but patients receiving ACP showed a significant steroid sparing, and this aspect of steroid sparing and reduction of immunosuppressive drug has been reported also in other studies, retrospective and prospective studies. There is a number of consensus suggesting the usefulness of ACP in chronic GVHD, and particularly the last Italian JITMO-SIDEM consensus suggests the use of ACP in patients with steroid refractory chronic GVHD as a steroid sparing strategy, but we are still waiting for a clear demonstration of a superiority of ACP in a prospective randomized study. Going to the acute GVHD setting, also in this case, Granitz published a preliminary report in 59 patients with steroid refractory acute GVHD by using intensive ACP with 3 applications per week in the first week, achieving more than 75% of overall response rate in patients with skin involvement, and similar overall response rate in patients with liver or gut involvement. In the subsequent studies, this kind of response have not been confirmed, at least in an organ outside skin. Skin remains the best target for acute SCP with reported overall response rate of 70-75%. Also in subsequent study, I would like to remind you a retrospective study compared by Agasia comparing ACP with anti-cytokine treatment in more than 90 patients with acute steroid refractory GVHD, showing that patients treated with ACP had a significantly better outcome in terms of overall survival compared to patients receiving anti-cytokine treatment. There are at least 5 consensus based on several systematic review. I would like to remind the more recent systematic review by Zhang, who examined at least 7 studies, including 121 patients with acute steroid refractory GVHD. Only prospective studies have been included in this series, and also in this case the overall response rate in skin was the best, 70%, but also patients with this liver or gut involvement showed acceptable percentage of response around 60%. And basing on this data, at least 5 consensus conference, American Society for Bone Marrow Transplantation, Italian JITMO and SIDEM consensus conference, British Bone Marrow Transplantation Society, and Photodermatologist British Society, Scandinavian and British Society, and European consensus confirmed the usefulness of ACP as second-line treatment in patients with steroid refractory or steroid dependent or steroid intolerant acute GVHD. What about the safety of this approach? ACP is a quite safe approach, particularly in adults, but also in children. This approach can be used both alone and in association with other immunosuppressive treatment. The main hematological contraindications for ACP administration are represented by severe cytopenia, particularly leukocyte count under 1,000 is a contraindication for ACP administration, while anemia and thrombocytopenia are relative contraindication because we can support this patient with transfusion of irradiated platelet or red blood cells. And what about non-hematological contraindications? Fever is not an absolute contraindication for ACP, while severe infections represent still a contraindication for ACP. And finally, severe cardiac failure or patients with severe renal failure are not candidate for this kind of approach. In conclusion, ACP represents an important support for patients with steroid refractory acute and chronic GVHD, and is a very important tool in order to reduce the immunosuppressive drug and particularly to spare steroids in patients with chronic GVHD. Many thanks.